Your slide is visible, ma'am.
Yeah, just let me. Right. So I have prepared a few questions, very basic, right? Some of the things we already covered in the case related to the case that Cable presented itself. All right. So chat. I don't know whether I'll be able to see the chat. So this is regarding one question regarding bilirubin metabolism. You have to tell us which of these statements are false. Right? So one is bilirubin is formed from biliverdin catalyzed by biliverdin reductase. Equimolar carbon monoxide is produced during conversion of bilirubin to uh, biliverdin. Bilirubin is converted back to biliverdin by reactive oxygen species. Iron gets eliminated from heme oxidation catalyzed by heme oxygenation. An ion is recycled. And exhaled carbon monoxide could be used to assess bilirubin production. So which of this statement is false? So I'll give you 1 minute so all of them can answer. Okay, so we have got a few answers. I will just go to the next slide. So none of you have got the correct answer. So let me show you. So the correct answer is B, right? So carbon monoxide is produced when when heme is converted to biliverdin by heme oxygenase. So that is the only reaction in the body which produces carbon monoxide. Rest of the statements are true. All right. So here the molecules were wrong. It's not bilirubin to biliverdin. So, okay. So if you can see here, heme and globin is split, and then heme is converted to biliverdin, and heme oxygenase is the enzyme here, and then carbon monoxide is produced. Right. So this is one of the tools to check for hemolysis. And AAP guidelines also mention that if you want to assess for hemolysis, if we have ETCO monitoring, end tidal carbon monoxide monitoring, we can assess whether the child is having hemolysis or not. Right. So these are there are nomograms and there are percentile ranges given for ETCO. Right. So this is one of the tools. So you need to remember this flow chart and this diagram of how bilirubin is metabolized. And this is the only reaction which produces carbon monoxide in the body. Okay, so none of you got it right. So all of you can see, or you can see the chat. So this is a clear Bedke test. So we do this test to assess feto-maternal hemorrhage. We actually do this to quantify the feto-maternal hemorrhage. All right. So I want you to tell me whether the arrow one, the cell that is pointed out by the arrow, is a fetal RBC or a maternal RBC. Okay. So that was easy. Right. So it's the same principle that you do the APT test, right? Fetal hemoglobin, it resists denaturation. Only difference in the APT test, you use an alkali. In Cleo Bedke, you use an acid. Okay. So this was discovered by the scientists almost in 1957. It's an acid elution which is performed on a maternal blood smear, and then you put an acid solution like a citrate phosphate buffer, and then the hemoglobin F is resistant to acid, it remains intact, whereas hemoglobin A is removed out, extruded. So the maternal cells appear like ghost cells. But this has got a little bit low sensitivity, like you need at least an fetal-maternal hemorrhage of 5 ml for it to be positive. You count 2000 cells and then you see the percentage of fetal cells to maternal cells. And depending on that, you can decide whether, so this basically is done to decide whether we need more than 300 microgram of anti-D. So the dose for anti-D is 300 microgram. But if the FMH is higher, then you need to give higher dose of anti-D. So you need to give dose-specific anti-D to mothers to prevent sensitization. And there can be false positive. If there is maternal fetal hemoglobin, then it can be false positive. Okay, so that is the clear Betke test. All of you got that right. Okay. All right. I hope I didn't see that. So regarding anti-D prophylaxis, all statements regarding antenatal prophylaxis of Rh negative mothers is true, except. So again, you have to pick up the false one. So the first one is all Rh negative women should be tested for sensitization at the time they come to the hospital. So the first time they visit, whichever first trimester, you need to do the ICT and see whether they're sensitized. So whether, okay, the next statement is dose of anti-D immunoglobulin for any first trimester event is 50 to 100. Anti-D prophylaxis should be given only to Rh negative women with an Rh positive partner who is ICT positive. All non-sensitized Rh negative women with Rh positive partners should be given 300 micrograms at 28 weeks. And additional 10 micrograms is needed for every 0.5 ml of fetal RBCs. So you have to pick the answer, the statement which is not true. Okay, right. So this was easy as well. Okay, so the answer is C. In fact, if you find that the mother is already sensitized, you will not give anti-D to that mother. So the first statement is right. Every Rh negative mother who comes to us in the clinic or obstetric, at the time of registration, you have to check ICT. If she's not sensitized and some event happens in the first trimester, like abortion or anything, then you will give 50 to 100 micrograms. If she's not sensitized, and even if she doesn't have any event, you will still give a prophylaxis of 300 micrograms 28 weeks, like how the patient cable presented the mother had taken. And like we mentioned in the previous, if you do a clear Betke and you find that the feto-maternal hemorrhage is more than 15 ml, which usually is covered by 300 micrograms of anti-D, you will give additional dose according to the quantification of the feto-maternal hemorrhage. Okay, excellent. So that was right. So this also we discussed. So you do, so we all said that we need to do a middle cerebral artery PSV to check for anemia. So what is the value at which you would say the baby is having, fetus is having moderate to severe anemia? Is it more than 1.5 multiples of median? Is it less than 1.2, less than 1.5, or more than 1.2? Moderate to severe anemia, fetal anemia. So most of you except one has got it right. So good. So you all know you're already preparing for exams, I guess. So first of all, it is more than, right? Because when there is fetal anemia, then the stroke volume increases, the blood viscosity decreases. So the blood flow to the brain, in an attempt to maintain the brain oxygenation, the blood flow to the brain increases. So first of all, the flow will increase, not decrease. So you should not get confused there. And these are the nomograms according to gestational age you have to see. So this is the peak velocity and these are the gestational ages. These are the green ones are the median values. Okay, and the blue ones is for mild anemia and the red triangles are for moderate to severe anemia. So anything more than 1.5 medians or multiples of median, you will consider this child as fetal anemia, a significant fetal anemia. You would do a chordocentesis, check the baby's blood group, check and if needed, you will monitor her, and if needed, you will do intrauterine transfusions. Right? It is a very useful test. It has got very high sensitivity, low inter-observer, intra-observer variability because there is an algorithm in place. It is non-invasive and you can do it multiple times to detect fetal anemia early, right? So this would be the correct answer. So RH and ABO are the two most common cause of alloimmune hemolytic anemias in babies. Now, among these characteristics which are listed, which one is shared by both? Which is the characteristics common for RH as well as for ABO? One is availability of effective postnatal treatment. Second, intensity of positive result on direct Coombs test or direct antiglobulin test. The likelihood of manifestation in the first child in the family, occurrence of spherocytes, and severity of the intrauterine impact. Which one is common for both? Okay, so again, most of you have answered correctly. So the answer is the first one, right? Because the intensity of positive, the DCT is more higher in RH compared to ABO, right? Second thing, RH will not happen in the first child, less likely. ABO can happen in the first child. Spherocytes are not seen in RH, whereas spherocytes will be seen on a peripheral smear in ABO. And intrauterine impact is higher in RH and not in ABO, right? So the most commonsensical answer here is availability of effective postnatal treatment, right? So I will, I have one more, this is a little tricky one. So I will give you 2-3 minutes to answer. You have to match the following. Okay, so these are some of the reasons why you will have jaundice in babies. So you have to tell me which test and which inheritance. So you can be like 1B or 2C, that kind. So you have to have 4 answers when you give your answer. So I'll give you more time. So all of you type all 4 answers together. I will give you 2-3 minutes. Okay, I can't see any answers. So let's wait for another 2 minutes. A3B1. C4. D3. All right, so you all have given multiple, I think most of them are right. So none of these would be X-linked dominant. So there is no hematological disorder which is X-linked dominant common disorder, right? So let's see I'll show you the slide. So osmotic fragility is a test that you do for hereditary spherocytosis. Okay, and inheritance, common inheritance, it can be autosomal recessive also, but commonly autosomal dominant. The second one, where you can see Heinz bodies, is G6PD deficiency. So that is X-linked recessive. The third one, I think the third one was a little tough. Impaired ATP production is pyruvate kinase. So that is autosomal recessive as well. And the last one is a hemophilia baby. So that is X-linked recessive. Okay. Yeah, Dr. Nalina, I'm done.
Thank you, ma'am. Yeah. Thank you, ma'am. Thank you so much. Audience, attendees, any questions you have? If you have, you can put it in the chat box, or if you want to talk, I can unmute you all. I think we don't have any questions, ma'am. Thank you so much. Thank you so much for taking out your time for this session. And the OSCE's questions were really good. Thank you. Thanks a lot, ma'am.
Yes. Thanks, Dr. Nalina. Thank you, everyone. I think
Thank
all
you,
are
ma'am.
preparing hard for exams. All the best. Let's end.
Yes, ma'am. Yes, ma'am.
Good night. Good night. Everyone. Good night.
Good
Good
night,
night,
ma'am.
ma'am.